We'll go ahead and get started, and I think some folks may join along the way, people gathering lunch. And so I'm going to go ahead and get started with this webinar. Just a couple of housekeeping items. I really just want to thank everybody for joining and making time on this Friday afternoon or kind of morning if you're on the West Coast. Thank you for being here for this webinar. It is being recorded, and we will make the recording available to everybody that participates. Send that out afterwards. And please, I invite everybody to submit questions here. Ellison Glantz is in our marketing department, and she's going to field those, and I also will try to pay attention to those. But as we go through this webinar, please feel free to submit specific questions or comments or things that are working or not working that relate to the content we're going to be talking about. I am just really pleased to have Beth Engelhorn and Dale McQueenie here. I'm going to ask each of you, if you could, just spend like maybe a minute introducing yourself. I'm going to then go through just a couple of slides I have about an orientation kind of to leveraging virtual mental health care. You can see the PowerPoint there, just a few brief slides, and then I'm going to come back to Dale and Beth and go through some questions because they have a lot of expertise in this area. So Beth, why don't you start? Just give a quick minute overview of you and where you work and the program there.
Okay, my name is Beth Engelhorn. I'm the Executive Director for Southside Behavioral Health. We're located in a very rural area in South Central Virginia. We are what is called in Virginia a Community Services Board, which means we provide state, federal funded community mental health care for mostly Medicaid population and severely mentally ill, substance use disorder for adults, children, and intellectual disabilities. We provide services for approximately about 3,000 people. Our MAT program is fairly, I'm going to say new, but has really taken off in the last year. So we're really, and we've been using a lot of virtual care. So we've been leveraging that pretty heavily within our agency. So thank you, Dr. Milam, for having me here today.
Thank you, Beth. And Southside has been a partner with IRIS for many, many years. I've helped out at the clinic there in Virginia myself, and so where IRIS started. It started with community mental health centers in Virginia, just providing extra care. And Tariq Shaheen, our founder, then realized it was a great opportunity if you could do this virtually and serve a number of different places in Virginia. And then he got another provider to join him. And from there, IRIS was born over 13 years ago. Headquartered down in Dallas now, but have really grown through just organic growth, starting a community mental health care, which is our biggest partners, but also SUDs and other areas where folks are trying to implement mental health care, EDs, just all sorts of places. And certainly with the opiate epidemic, it's just hitting a lot of our communities. And right here in Virginia, and where we are, is where a lot of the opiate epidemic started, and it's still a big problem. So thank you for you and your organization's presence. Dale, tell a little about yourself. Dale's been with IRIS for a long time as a provider, and we're glad to have her here today. So over to you.
Thanks, Dr. Milam. Yes, so my name is Dale McQueenie. I'm a psychiatric mental health nurse practitioner, and I specialize in substance use disorder treatment. I've been with IRIS for just over 4 years now, and I'm placed with the Center for Human Development, which is in rural Eastern Oregon. And I was brought on to be the primary prescriber for their MAT, their newly developed MAT program. And it's been wonderful. I now also serve as their Associate Medical Director for Substance Use Disorder Treatment. And their MAT program has grown quite a bit. And as their primary prescriber, since I live in Maine, it's all virtual. They do have 2 prescribers who do have some clients, but very few. All new clients see me. So it's been wonderful.
Great. But appreciate that, and it's incredible work you both are doing, your teams, and I know folks are excited to learn from your experiences. Let me, I think folks can see the PowerPoint. I'm going to have it on a different screen here, so I'm going to look over the side. But the topic for today is, you have seen, is leveraging virtual care for MAT, best practices to improve access to care for patients with substance use disorders. A huge need, and just a couple of slides here to point out, just some audience may be familiar or not as familiar with this. I know there is this opiate epidemic, and we hear that, but sometimes some of the nomenclature used, some people call it MAT. I say MAT. Some have OBOT or OBAT, but it doesn't really matter, as long as I think people all know what you're talking about. But I just call it MAT. But what are we talking about here? A lot of this is not just about opiates, but it's about opiate epidemic, and want to understand some of why it's an epidemic. There are natural opiates, and you think about that, from poppy plants. It's not like you can just pick them and eat the little tiny seeds and get high, but they are the derivatives of natural opiates that lead to things like the creation of morphine and codeine and other things that we're probably most familiar with. They're semi-synthetic opiates. They're naturally occurring, and then they've gone some chemical changes to how they're formulated for how they're used. And that is everything from commonly used drugs like oxycodone and oxymorphone, buprenorphine, but also heroin, semi-synthetic. So those have been some of the big problems, and throughout much of my 25-year career, heroin and things like Percocet, Norco were more of a problem. And then the synthetic opiates came in, and just cartels developing things, just distribution networks. And tramadol, it's a pain drug that I've used and prescribed with patients. Also methadone that we use and prescribe, and then fentanyl and the fentanyl derivatives. And that is where these synthetic drugs that are easily made and shipped and used by people, misused or abused, has been a real problem. And that's kind of what we're going to focus on. When you look at opioid overdose deaths, this is from 99 to 2020, so it's like a 20-year period. It's interesting, as I said, that heroin, had been something that we read about, or dirty heroin, or all sorts of things throughout much of my career. Methadone has kind of been there, but methadone programs have always been there, so it's kind of leveled out. But you look at this trend here, this is a concerning one, the synthetic opiates, other than methadone. Look at the usage rate starting around 2013. Oops. And you look at 2013, and it just started skyrocketing. The ability to make these drugs really outside of the US and illegally within the US has led to real problems. And that peak there is really one of the problems that we're looking at, is the huge trend of synthetics, and help people understand what that is. So when you look at the percentages of overdose deaths involving drugs, it's really interesting. Most overdose are with opiates. You also get them with stimulants. These are any opiates, but illegally made fentanyls are the majority of opiate deaths. You see here, like prescription opiates and heroin, things that were big concerns before, are a very low portion of the death. They're still significant, so we have to continue to work there. But the illegally made fentanyls, and some of them, their price point is really low. It's just made them so available. When you look at, they are the highest cause of opiate deaths, is illegally made fentanyls and other, with no other drugs. That's it, number one. Secondly is those mixed with cocaine, 21.4%. Third highest is those mixed with methamphetamine. When you look at like cocaine with no other stimulants, or methamphetamine with no other stimulants, around 5%. So you can see that adding fentanyl into any other drug, or fentanyl by itself, is very, very dangerous. And when you look at these overdose deaths, there are certainly people who are suicidal in overdose, but what I think a lot of us read a lot of is that there are people that either don't understand how strong some of the fentanyls are, that they don't know that it's present in drugs that they're buying or using, or it's mixed in with other things, or what it's cut with, or really it's just so powerful that you think, using a small amount has such, that it's just not going to hurt you that much. But that's why the intervention about education, but also having like naloxone kits and things like that, places for people to get help quickly, education for what to do if you find somebody that's out or passed out. Naloxone is being used a lot more now, just automatically, because it can reverse things fairly quickly. So, what's the role of medication-assisted treatment, MAT? I think it involves a lot of things. It's not just about prescribing buprenorphine or methadone or things. It's about counseling, therapies, having people engaged in treatments, whole patient approach to it, and look at what's the best way to help folks have a better approach that they can really engage with, feel supported by, not with judgment and guilt, but with support and compassion for the whole person, trying to address mental health issues as well as the addiction issues they may have. The benefits are tremendous. Decrease in opiate-related overdose deaths, decrease in illicit opiate use and criminal activity, increases in their social functioning and retention and treatment, decreases in HIV and hepatitis, and for those that work with pregnant women, postpartum women, really better outcomes for pregnant and breastfeeding women. So it's tremendous impact on people, and I've been fortunate over the years to work with many, many people involved in this area, as people like Dale and Beth. So I'm going to go out of this and start this moderated discussion. I'm going to leave I'm going to stop sharing, but while I figure out how to do that, I'm going to, Beth, I'm just asking you if you could say a little bit about how do you fit MAT into your organization? Like, is it a separate program with separate staffing? Is it integrated into other things that are going on at Southside? And just if you think about like a community mental health center at FQHC that wants to do this more robustly, what's worked for you? What have you learned? What's worked? What hasn't worked?
Well, I would say when we initially started MAT, we have an OBAT right now. We started it as a separate service and quickly learned that it really needed to be integrated into the mainstream services of the agency. We offer it almost hand in glove with everything else we offer. So if somebody walks in the door, we do a comprehensive needs assessment and figure out everything they need. If they want treatment for opiate disorders, we send them in that direction. They see our nurse practitioner, who is also the nurse practitioner that prescribes all of our other mental health medication. And we have just recently hired a psychiatrist, actually, through IRIS, who also helps us with that. So we just consider it part of the treatment continuum within the agency, and don't differentiate between that and anything else that anybody comes in for. We do have specialized staff that treats substance use treatment. I mean, they have more experience than other people do, but they treat the whole person. So if there's a mental health component on board, we work with what the individual wants to work on. They choose their course of treatment.
No, that's great to hear. I think that whole person approach is really great. There's always this chicken and egg thing of, do you have a mental health disorder or anxiety and then use drugs as a way of self-medicating, or does using drugs or having addiction issues then lead to depression or anxiety or shame, guilt, all sorts of things? I don't know. Let me ask you, Dale, like in your experience, what are some of the sort of unique challenges, both the joys and challenges of working with folks that are struggling with opiate addiction and coming to you for help?
Well, for the patients I serve, there's a lot going on. It's not just opioid use disorder. They're usually dealing with co-occurring, as Beth said, they're usually dealing with co-occurring mental health diagnoses, which really need to be addressed in order to have the best outcomes, and which they complicate their recovery. So again, that needs to be addressed. And they're usually facing socioeconomic challenges such as homelessness, food insecurity, lack of employment. They're also often involved with the criminal justice system. Most don't have a primary care provider and haven't had a history in physical or dental care in ages. They need a lot of support, more than just a buprenorphine prescription. So it really takes a team approach. We also are integrated. We started as a separate MAT program, but now we're integrated. And that was mostly due to a grant, but now it's integrated. That grant has passed, and so it's integrated into the rest of our services. But we do have an SUD team. So we have dedicated certified recovery mentors, for example, and case managers who can respond to all these many needs that our clients have.
No, you raise an important issue, and I think there's probably general acknowledgement that all of us have complex lives and face social determinants of health issues, some more than others, some way more than others, whether we have addiction issues or not. There's just a lot of stress, a lot going on in people's lives. As you mentioned, food and housing scarcity, lack of support, hopelessness, feeling disconnected from society, and and so I know the work is, when folks come in for help, part of it is just, I think, creating an environment where they can feel held and cared for. I mean, Beth, what have you seen? You're doing this stuff a long time, and among you and your staff, what are some of the strategies for when patients present? I know there's lots of forms and logistical things. How do you navigate that at the same time, not feeling like, hey, you come in and we're treating you like a number? How do you handle that in your organization?
Well, we believe that it starts at the front door. So in the first phone call that they make, they have to feel like they belong there. We have shifted our substance use services to a harm reduction model. So we work through the paperwork as quickly as we can, but still providing a comprehensive assessment to figure out, as Dale said, all of their needs. So if they need peer services, if they need care coordination, if they need whatever they need and agree to for services, we try to set them up with that. And we try to make it as painless as possible, but still filling out all that, because we're a state agency, all the information that's required. I think that our team is actually really good at working through all those assessments, explaining why they have to be done. We are a grant-funded program in regards to our MAT right now, and so there's an additional assessment called a GIPRA that has to be done. But we make that a reward, so we give a gift card if they complete the GIPRA. We give them something for it. So it's I think we as a team work really hard to make the person feel heard, and that they're not just a number or a piece of data. I think we work really hard to see the whole person that walks in the door.
Yeah, that's wonderful. I appreciate it.
We did those at first too, the GIPRAs with the reward too. Yeah.
Yeah, that's great. I was just giving the providers some gift cards for completing a survey. I mean, you got to motivate people. It's
Right.
Dale, but what about from your perspective? You got like a new patient coming in and they've filled out some forms and maybe they still have to do some stuff with you. And what are some techniques like you're sharing with organizations that may be really wanting to embrace this, not knowing how or how to create an environment where folks struggling with addiction issues can feel welcome and respected? What have been some of the or guidance that you've had for the folks based on your working with people for that, like that initial stage of engaging in treatment?
Well, I like to have the first, I really like to have the first appointment be with me over video. I like to see, I like them to see me. I know audio only is allowed still, which I think is great. And I want the services, we try to have a harm reduction approach too. And I like the services to be as low barrier as possible, but I really like that first appointment to be video so they can see me, so we can make eye contact. And then subsequent appointments can be telephone if it's difficult for the patient to come into the office. But the first appointment by video in the clinic allows me to get a urine drug screen at the first appointment as well. But, you know, almost all of these clients or patients, it's a lot of stigma. So, you know, I try to bring a sense of and non-judgment in all my dealings, and I listen. I think that's the most important thing is I listen, and it may sound cliche, but I meet them where they're at, and I get to know them as people. And so again, low barrier, non-judgment, harm reduction, all of those techniques I try to bring.
No, that's really wonderful. It's wonderful. And there's been a lot of transition, even before COVID, but during COVID, with having morphine be more available, from very limited panels to having the DEA do spot checks. I remember them coming to my office and through DEA agents, like, we need to see your list, just like this monitoring type thing, like, that almost made you as a provider feel kind of scared, like, oh my gosh, is something going to happen to me because I prescribed this? And so I do have providers that say, I don't want to work with that population, or I don't want to prescribe those meds. And I get that, but in my workings with the DEA, they feel very differently towards providers. They want to partner with us. And I do believe that the legislation is going to be forthcoming from the DEA, hopefully this summer. Some initial guidance for 2025 is going to continue to be very similar to what it is now, creating an environment that is not punitive with lots of hoops for doctors or patients or nurse practitioners to have to jump through, because people need access to this care. A harm reduction model. We're beyond trying to just convince people that it's a good thing, and I think it's okay, let's continue to make it a good thing. The removal of the data waiver was a great thing to make it more available, and for having different prescriber types being able to prescribe it. Tell me, Dale, you mentioned like urine drug screens and things like that. I do know that when you're starting a new opiate or even buprenorphine, you got to check the prescription monitoring program and log that you did. There are urine drug screen requirements. There's consent forms. Tell me how you handle some of that process, because the logistics of that can be a little challenging for patients. Coming out of COVID, what do you see are some of the easier ways of doing that, getting through some of those hoops with patients?
So I almost always obtain a urine drug screen at the initial visit. And that's, again, why I like to have it in person for the first visit. That facilitates that. The frequency of subsequent urine drug screens, I think, is nuanced and depends on the stability of the patient. If I have concerns, I certainly obtain one, but my patients tell me what they're using. So I'm rarely surprised. And I think the communication is key. I communicate to them that I'm not going to stop prescribing to them if they're positive for a substance. So it makes it easy for them to tell me what they're using, and they do. I can't remember the last time that I was shocked by something showing up in the urine drug screen. I really can't. And the information that I do get in a urine drug screen just guides me in how to best support them. For the most part, I mean, one of the things is most states do mandate e-prescribing for controlled substances. And like you said, it's usually required that you check the state's prescription drug monitoring program. States do require that, most of them, prior to prescribing a controlled substance. And this can often be integrated into your EHR. We don't have that, but that would be nice. But it's a nice thing. And like you said, the data waiver caps are no longer a thing, but it's still helpful to track patients who are enrolled in your MAT program. There are other reasons why it can be helpful to do that. Some payers require that patients be seen within a certain period of time. So that can be helpful, and you can assign codes in your EHR for that purpose.
That's great.
We do that. And I think that's all I have on that for now. I can talk about the frequency of like prescription pickups and how long I write for, if you find that helpful.
Yeah, let me come back to that for both of
Okay.
you. When I asked Beth, like, how do you all handle urine drug screens? I will admit that myself, I often get one initially, but as Beth said, I sort of see that every test that you get has to have medical necessity, because there's going to be a charge for it. It's got to be medically necessary. And so some people are fairly strict of getting them, or I hear from providers that they fear the DEA is going to come down on them if they didn't get them each year, or some frequency. I was like, where are you getting that data from? Because it's not true. If it's medically necessary to guide treatment, then you get it, or you get it initially. After that, it's up to the provider to sometimes wonder, what is it going to show? Are you looking for the drug not being there that you are prescribing? Or is that going to change things? Or are you looking for other drugs with maybe buprenorphine or methadone? Is that really going to change things? So how do you all approach that there, Beth?
Well, we have, we're kind of unique because we live in such a rural area that broadband and internet access isn't available everywhere. So I would say the vast majority of our clients actually come into the office and see a therapist virtually in our office, using our equipment. So we get a drug screen when we open them up for services as a baseline, and they know that in advance. We tell them, these are the things that are going to happen as you come into services, so that they're fully aware. And then it becomes whatever the provider feels is appropriate for the individual. And they, like Dale said, they talk with the individual. I would venture to say that they all know what is going to be on board when they do that urine drug screen, and it's not going to be any big surprise to anybody. But it is informative. It's informative for the provider to have a conversation with the individual and say, so here's what showed up. Let's talk about how this could affect your treatment. Let's talk about how this could affect, your safety. And we just provide information and let the individual make the decision as to how they want to move forward at that point. I mean, you do get to a point where I have had providers say to clients or some of our patients, if we keep going down this road, we're not going to be able to provide you with X, Y, and Z, because it's going to be it's not going to be in your best interest. But it is a conversation. So I think we use that as information to have dialogue with the client and ask them, how they want to move forward.
Yeah, I think, you both have a wonderful approach, and you both experienced in this field. I think I still encounter providers who are uncomfortable treating folks with addiction and are unsure of what happens when I check a drug screen and I've got somebody on buprenorphine 2 or 3 times a day, and they come in and they have meth in their drug screen and buprenorphine and marijuana and maybe something else. And like, oh my gosh, I'm gonna somehow be held liable for prescribing buprenorphine. I'm trying to encourage people to see things differently, which is that this is about keeping people alive. This is about an epidemic, pandemic of deaths and overdose, mostly accidental. So the education and support is more important than, jumping through various hoops and things that push people out of treatment. And I think that's changed a lot. I don't know if that makes sense, or Dale, you want to reflect on like the transitions you've seen in terms of the patient experience and requirements in their engagement?
It's super common for my patients to use substances other than opioids. I mean, the vast majority of my patients are using methamphetamine and cannabis as well. I think that there may be regional differences, but for my patients, it's methamphetamine and cannabis. And methamphetamine is often laced with fentanyl these days. So I talk to my patients about that, and I recommend fentanyl test strips if they're going to be using meth, and maintaining a harm reduction approach. Certainly abstinence is, what I would prefer, because, you get better outcomes that way, but I'm also realistic about that. And I also talk to my patients about cannabis use, because I tell them I don't think it's good for the brain. And I talk to them about the risks for paranoia, psychosis, if they've been experiencing that. I use motivational interviewing and try to move them toward change. But I'm mindful that, and also alcohol use disorder, I think that's undertreated. So I always suggest, I always try to prescribe MAT for alcohol use disorder when I make that diagnosis as well. So, but again, methamphetamine and cannabis are very common substances that I see used along with opioids.
Beth, what's your experience there at Southside in that same vein of?
I would say we see a lot of cannabis use, and the our providers were, we've had to move them along, in terms of providing them with education and experience and talking with other providers who are comfortable with a more harm reduction approach. We've had to really provide a lot of training to get them comfortable with that whole idea. But they've really, I think, our in-house providers have really come a long way in that approach. I mean, we just started offering people harm reduction kits where we give out fentanyl strips, syringes, whatever somebody's going to need to keep themselves safe. So our providers see methamphetamine, they see cocaine, they see marijuana, they certainly alcohol. And they do the same thing Dale does. They have a conversation. They talk about the risks, increased risk, to their health or to general health, and it becomes, like I said earlier, a place of dialogue where they might inform their therapist, hey, I just want you to know that they tested positive for cocaine and amphetamines in their drugs. So you might want to have a conversation with them or reiterate what I've said. And the provider that I work with, the nurse practitioner the most, he reads my notes. I mean, and he reads my notes, and I have conversations with him about our shared clients. And so, and we tell our clients that we talk about you when you're not here. So, and I think that they appreciate that. They appreciate that team approach, that we all share concern for their health and safety.
Yeah, that's wonderful. I think that concept of creating an environment where people feel held and cared for. And I think there's so many negative features in society that make people feel isolated and alone. And I think despair, hopelessness, whether you're using substances or alcohol or not, there's a lot of that just being a human. And all over the world, people are struggling with food scarcity and housing scarcity, and so I think everybody's trying to lean in now And I hope that over time we really create an environment where people are struggling with mental health issues or addiction issues don't feel like we're going to punish them for failing. Like you come in, you're on buprenorphine, you're positive for cocaine, and says that you can't use that anymore. I'm going to stop prescribing. Because I remember it being that way 10 years ago or 25 years ago. It's really changed from looking at that data that says your risk of dying when you're using both of these things together is really high. And this is about staying alive. I think for some people, there is the addiction, the brain chemistry. I also think that some people, they don't feel their life is really worth living. They just don't care. Um, how do you convey that, Dale, that sense of, we're going to support you, we're going to prescribe these medications to help you? It's more than just about the medications. What are, I don't know, are there things that you say to people that you find or that you would share with others that are helpful to patients, or things you found that click with patients that help them stay engaged with treatment?
I do use a lot of motivational interviewing, and I grab onto those little kernels, that little bit of hope, and I hold hope for them. And I say things like, I'm trying to keep you alive. I think you're worth being here. And because they are, all of my patients are worth being here. And, I just find those little things and there's always something that you can grab onto.
Yeah.
You have to look for it.
Yeah. Yeah. No, I think just being a person of hope. People have said, I've had
My
patients.
sign.
Yeah, there it is.
Yeah,
It's hope. It's
always there.
Yeah.
And that's why I have it there,
Yeah. You're right. And a lot of people will just say, I don't have hope. And often I'll just say, well, I believe in you. I'm hopeful for you. Sometimes just that human connection is important. It really is. So let me ask you both, Beth, starting with you, how has the virtual care component impacted things? I mean, the VEA's allowance to use audio only to treat folks was huge, because I remember people had to come in for methadone. You used to have take homes each day until you can get to weeklies. You had to have a group and each week, and you didn't get your prescription. We handed them out to people at the end of the group, and then they all went to the pharmacy, or they all went and got their drug screens and then came back. It was just so many hoops to jump through. But how has virtual care been received in your organization, and how's it been best used to serve patients?
Well, like I said, we're stretched out across about 2,000 square miles. We're short on providers. We don't have enough providers across our catchment area. And so what virtual care has allowed us to do is to provide services when and where they're needed. So if a person is in one end of our catchment area and the provider is in the other, that doesn't stop a service from happening. We just connect them virtually. And the patient really doesn't feel that. It's seamless for them. They don't have a sense of it being different, because they see their providers, that's their consistent provider. Virtual care has allowed us to bring in professionals, psychiatrists, nurse practitioners, therapists, where we wouldn't be able to have them in our area at all. Our MAT program would probably not exist if we didn't have virtual care. So it has actually allowed us to bring this to our community and let it grow.
Yeah.
And not only that, to have really competent, talented people ready to provide those services. So I don't think that we would be in operation without virtual care.
Yeah, that's a great point. I think Iris worked with many folks in your organization before COVID, but COVID was a game changer in terms of everybody having to sort of clinics having to pivot and find a way to serve patients. Luckily, CMS and the DEA pivoted really quickly because people weren't going to die without access to care. If we had to care, they couldn't come in person. It's and so it was a real game changer to see that, and because I think things would be so much worse if it didn't have virtual care, if everybody had to come in person for every visit and see an in-person provider. How could any clinic do that? I don't know they could. And I think legislation and things are expanding to invite more people into care. And like you say, in rural areas, but even in urban areas, there's just a shortage of access. There's long wait times, and people die while they're waiting for care. And that's really sad, but we're all working on that together. What's been like for you, Dale, to being a virtual care provider? Because there are people that are thinking about it. Everybody did it during COVID. Some people really like it. They like working from home. Some people sometimes maybe feel it's lonely, like they're seeing patients and they're not around staff. Sometimes it's they want to interact with people more. What's it been like for you working with folks with mental health issues or addictions virtually, and what guidance would you say for helping people decide whether they want to be a virtual provider?
I love it. I wouldn't do anything else now. I can't imagine going back to an office. I mean, it very much suits my personality. I've done both. My first job was at a community mental health center. I was, live and in person, and that was fine. But I wasn't strictly working or primarily working in substance use disorder treatment, and that's what I love. That's what I love doing. I started working with Center for Human Development through IRIS the first week of the shutdown of the pandemic, and I've been doing it since then. And I actually don't notice a difference with. I mean, that was a dramatic thing, the pandemic, but I don't notice a difference in my interactions with patients virtually. It feels the same to me, and I have a lot of interactions with the Center for Human Development staff. I feel that I'm just as connected with staff as I was when I was in person. I don't feel lonely. I don't get out of the house a lot, but again, that suits my personality. But I'm very interactive. I'm very interactive with other people. So I don't feel loneliness. I don't feel alone. I wouldn't change anything. I don't notice a change in my interactions with my patients at all. I feel like I can make the same connections even by telephone, because a lot of my appointments are still by telephone. Patients seem to prefer it, at least where I am, and I see it as the power of telehealth. Reaching as Beth was saying so eloquently, it's reaching those in need who might otherwise be underserved. I think it's just so cool that I can be in Maine and, interacting with patients in rural Eastern Oregon. It's fantastic.
Yeah, it really is fantastic. I love just the power of telehealth. And
Yeah.
you said that Tarek, who founded Iris, had these T-shirts that said, telehealth, it's a big deal, that kind of stuff, way back in the day. And Beth, could you speak to just the adoption there? Because in some places we've had people say, I really believe in person is best, and we agree. It's great to see people in person if you can. But we've often run into working with organizations where you have some people that really embrace virtual care, and some are very hesitant and still want patients to come in, to be in person in the clinic, to connect. They don't want them connecting from their homes. Yet, I've seen patients in their cars, in their homes, wherever they can get a good connection. And it's been interesting because normally you're not invited into people's homes unless you're doing like mobile crisis or you're a social worker. What's that been like, the transition to virtual care, and how staff has done that, and for them and for the patients?
It was slow going at first. I mean, people did see in person as the gold standard. And I will say that, when you get an opportunity to do that, it's a wonderful thing. Um, but I also feel like, that Southside's mission is to bring services to the community. And so we see the community as getting services when and where they need it. So if they need it in their home, we do it in their home. If they need it in the clinic, we do it in the clinic. If people are homebound, for whatever reason, let's say they just had surgery, or they're afraid to leave their house, or they don't have transportation, or weather is bad that day. We connect. We have an EHR that has a virtual component, so we can go right through our EHR and see people virtually through that. If they set that up with us, I think that talking with other providers who can share what Dale did about the advantages of seeing people virtually. We talked with VCU about doing inductions with people at home, and they do 90% of their inductions with people at home. So, and they find that they're very successful. And so I just think, information sharing and seeing how successful it is important. It's important for our industry to share those successes and say, we used to write on a chalkboard with chalk. That's how we used to do it. We don't do that anymore because it's not as efficient and you're not helping as many people. We're here to help people. Let's help people, as many people as we can.
Yeah. Oh, that's wonderful. I keep this little over here, this statue belonged to my grandfather. My father's fetching the doctor. It's a young boy on a horse who went to get the doctor. And I say that because kind of like what you said, it's still the same. It's connecting the provider to the patient. You used to do it by horse and then by, a crank phone and things like that. This is still the same care. It can reach more people because we use technology effectively, and patients it seems like they want to use it. Everybody has a phone, everybody has the ability to connect, and particularly being able to connect audio only when you need it, to stay in touch with people so that you can make sure they have their prescriptions and have access to care. I think there's a lot of evolution happening in kind of what my experience in COVID, what I learned was, it's between appointments is where a lot of problems happen. How do we connect to people between appointments and create environments where they relapse, and they're scared to tell you because they're worried that you won't refill their medicine, but they're out. They ran out. They sold it to buy cocaine. Are they going to be punished? Yeah, or food. Yes. Seriously, you're right. Not punishing them, but saying, no, we will help you. We want you to stay alive. We believe in you. We're creating that partnership, and that creates that road to sustained recovery. And so this has really been wonderful having you both here to share your experiences. I learned something like the fentanyl strips, the test strips like that. Are those available publicly, or can you buy them?
We get ours from the Department of Health, I think. I might be wrong, but I think that's where we get them.
Okay.
I'm not sure where we get ours, but I know our certified recovery mentors, case managers have them available.
That's a great thing. So we'll put some resources out or blog about that, because it's I did not think about that. And you hear about cases of people stumbling into fentanyl on something that they didn't know, or children getting exposed to it. I know tomorrow is one of the National DEA Drug Take Back Days. So I've sent out a thing to all of our providers encouraging them to look in your cabinets for anything that you just don't need. Don't keep supplies around. Children and people can climb into things and open drawers and get curious, and so getting old medicines destroyed and out of possession is good. That educational piece, that we're here to care for you. We want to keep you alive with your family and connected, and not just get off this drug, but help you as a whole person. And I'm very grateful to the work that you and your organizations do to save lives and to treat people with respect and dignity that they deserve. Thank you for that. Any final thoughts? You each a minute or two, just if what would you say to organizations or patients or others that may be watching that you would just want them to know about getting help with addiction, any kind of addiction?
Well, we do a lot of public education. We do a lot of prevention work. We do a lot of Revive trainings, just getting people comfortable with the topic. We do a tremendous amount of public education, and I think that's made a tremendous difference.
It's wonderful. Yeah, education, huge thing, and inviting people in to engage. Dale, how about you?
Yeah, I just wanted to emphasize, the power of telehealth. I live in Maine, as I said, and became aware of how devastated New England has been by the opioid epidemic. And then I learned how other regions of the country were similarly affected. So now through IRIS telehealth, I have the ability to use my skills in education to serve the people of rural Eastern Oregon. That's all because of the power of telehealth.
Wonderful. Yeah, the power of telehealth. I really think it's been great, and I'm hopeful this is a good year for telehealth legislation to be finalized. Some of those things like the geographic barriers for telehealth, for treatment, for inpatient treatment, for ambulatory treatment, leveraging telehealth along with mobile crisis teams to be able to get providers virtually into homes, into communities. I think we're just on the cutting edge of some really exciting ways to expand access so that everybody has equal chance to get the care where they need it, when they need it. I know a big thing we work on with IRIS is wait lists for people on these long queues, thousands of people at sometimes one organization, 10, 20,000 people on a referral queue waiting for any kind of appointment. And I always think, wow, there's a lot of people that are going to die on that list. How do we get them in? And as you both said, there's a shortage of providers, and we try to recruit, great people, and do the best we can to get enough providers to serve those communities. But virtual care really leverages a provider's reach. I did get one last question here on telehealth platforms. Beth, you said yours is integrated into your EHR?
Yes, we have, we use Credible. Credible is our EHR, and they have we have actually a Southside Virtual Care. It's an app that you can upload onto your phone and attend your virtual session via that way. And we also have it set up in our offices. So if somebody doesn't have access to broadband, they can come into our office and see their telehealth provider in the office if that's what they prefer. It's a matter of client preference.
Okay. So it's an app that way. It's just they can just use that app and open it, and you're connected. It's not a lot.
Easy as just pushing a button.
Yeah, that's great. Gosh, that would have been nice many years ago. Dale, how about you? Anything specific for the tech standpoint?
We use a platform called MEND, MEND.
Yeah. And that's the EMR with the built-in video component?
No, it's a separate platform. Our EMR is called Echo Vantage, but our MEND is a separate video program.
Yeah, no, that's great. IRIS, we've never promoted any particular product or have a thing like that. We work with what organizations already have and help them get low price things and leverage laptops or iPads or things like that are just not as expensive as buying these huge carts and things. And so it's things are evolving, the technology is evolving. So great to hear you all have wonderful experiences with that. So thank you both for your time. I thank the audience for attending today. It's a really important topic, and more of these types of sharing and experiences and meeting together, I think changes people, changes hearts, and will save lives. So thank you both for being here. For our audience, thank you. We'll send out the recording to everybody, but I wish everyone a wonderful Friday and a great weekend.
Thank you. Thanks for having me. Nice to meet you, Dale.
Nice to meet you, Beth.
Take care, everybody. Thank you. Bye-bye.
Bye-bye.